Well, I am very excited to have this conversation today, Dr. Scott. Welcome to Beauty Uncovered.
Thank you.
I have been having a lot of conversations with a lot of different friends, my nieces, and we talk about hormones. But the truth is that with women, I mean, at least for myself, when you hear hormones, you think your menstruation, but you think of menopause, and then you don't really think of it outside of those two things, maybe childbirth or becoming pregnant. But really, in all honesty, our hormones are fluctuating throughout our entire lives. I would love to get kind of, first of all, an overview of when really do things start to kind of fluctuate throughout our lives, because I never was really aware of it.
Yeah. So being a traditionally trained OBGYN, I can tell you that we actually aren't taught all this. And so we have to learn how the hormones fluctuate during the normal menstrual cycle. We have to go through a little module on infertility and a rotation on that. But then if you are intending to just be what's called a general OBGYN, basically we know how to deliver babies. I could do an emergency C-section in a minute. I could cut a baby out, but we're not really taught anything, not very little on hormone related problems. That includes menopause, that includes irregular periods, that includes PCOS, polycystic ovarian syndrome, any of those things. And so that's the problem number one. Problem number two is the world is different today. I mean, I graduated from medical school almost 30 years ago. Next year will be 30 years. And I think we have more plastics in our environment, which are acting as endocrine disruptors and acting like estrogen. We have more insulin resistance from our food, more sugar issues. So that causes issues with your hormones, and we have more and more problems. So if you think about it, I don't know how old you are, but when I grew up and you were 15 or 16, we did not look like the girls they do now. And it's not about makeup and what they wear. It's also, they look so much older, and people are getting their periods earlier. And instead of seeing that there's a problem, the American Academy of Pediatrics changes the average age of periods to be younger instead of thinking that that's abnormal. So that's the problem. So normally I would have said, oh, hormones start fluctuating in your 40s. Once your period becomes late, that's called perimenopause. But I'm seeing women at all ages. I see girls, as soon as they start menstruating, I see a lot of teens for things like acne, painful periods, irregular periods for a more natural management, because all they're offered is birth control pills. And then I see a lot of women in their 30s, like even just early 30s, start to have hormone related complaints.
It's very interesting because I remember when I was young and I first got my period, and I remember the first time going to a GYN because it was so abnormal. It was completely abnormal. It was really heavy. It was painful as you could not believe. And yeah, they wanted to give me birth control pills. And I remember sitting there thinking like, and I got to be honest with you, I feel like it messed me up more than the actual problem that I was having. So I think that it's very hard to have these conversations, when that is the standard norm.
Yeah. So birth control pills are indicated for contraception, right? And so that's what they're FDA approved for. That's what they're studied for. They are not hormonal replacement. They are not hormone management. They do have some positive effects on your period in the sense that you don't have a period. You have what's called a withdrawal bleed. It shuts your ovary down. It doesn't let you ovulate and gives you synthetic hormones. And then when you have the pill-free week, you have what's called withdrawal bleed. So essentially what's not told to girls is that the longer you take birth control pill, there is a slight increased risk of breast cancer. So I took them for 10 years because, again, I had painful period. I was never told that. You're told of the risks of potential blood clots, but are you really told of all the risks? And the second thing, in a latest study, said an increased risk of cervical cancer, irrespective of HPV. So cervical cancer is the cancer that we think is related to HPV infection. Now we have a vaccine. So how is that have anything to do with your hormones? So I feel like birth control pills should be taken for contraception. If that's what you need, then you should take them, and that's what they're good for. But for cycle control, for painful periods, although that is an option of treatment, there's better ways to do things.
So here's okay. Still trying to understand mine. I mean, myself, I have no problem saying I'm in perimenopause without a doubt. But admittedly, I don't really do anything about it other than try to be careful with what I eat and this, that, and that. But I often hear the term hormone replacement or whatever it may be. And it's very interesting because when you go online and you try to research these things, there's so much conflicting information out there. And so when I hear, I like even hearing, when you're first ovulating, when you're young to anything else, I always just assumed that was something just for menopause. Is that something that could be at any given time as your hormones are fluctuating?
Yeah, I agree. The term replacement is very misleading, right?
Yeah.
And so we would like to say hormone balancing, but my traditional colleagues make fun of us for saying that. They say there's no such thing as testing hormones, there's no such thing as hormone balancing. Think about any other hormonal problem that we have. Diabetes, right? They check your blood sugar and they monitor and react to your insulin. Your dose may change on a day to day basis. Thyroid, they monitor your thyroid hormones and change your dose based on your body changing. And even, any other, if you have an adrenal issue and you're taking replacement for that, men who take testosterone, we check levels and monitor levels, but not for women. The guidelines are just to give women hormone therapy without checking levels before, without it's not embraced. The American College of Obstetrics and Gynecology and the North American Menopause Society says don't check levels and don't monitor levels.
Why do you think it's not embraced?
I don't know, because if you're a fertility specialist, you do blood testing to determine hormone levels, to determine the dose of fertility drugs. So if it's valid in that instance, that you can see how, if you have a good quality ovulation, if you had problems like that, why does that is not pertinent in someone your age? So for example, if you're telling me you have problems sleeping before your periods, you're having terrible PMS and heavy periods, that sounds to me like it could be with some abnormality in the cycle. Maybe you're
And
not.
yet, we're told that it's normal. No, that's normal. I mean, it's almost like it's almost like an antidote that you hear in like books and movies and television shows, like, oh, she's on a rag or whatever it is. Like,
Well,
oh yeah, she's a moody bitch,
it's common, but does that mean normal? Right?
Mm.
It's common. Yes, a lot of women have that. That doesn't mean it's normal, and that doesn't mean it's okay, and you have to put up with that, right? And so it's just this whole, I mean, the healthcare today is the way it's aimed is you have to wait till you get a disease and you get treated, right?
Mhm.
So if you don't have a disease, if you're having these symptoms, and perimenopause is a normal rite of passage, there's no disease, there's no pathology, but what people don't realize is that if you do have higher levels of estrogen that are not balanced from progesterone, that does put you at risk for breast cancer. That has been published. That data is out there. So again, if there's studies that show that these higher levels of estrogen in the perimenopause correspond with an increased risk of breast cancer, why are we saying we shouldn't check levels when there's studies based on it? Just, I don't know where it comes from. I don't know where. I know that there's this, and I hate to say, why am I aware of it now? Because I got on TikTok, a few months ago, and I've been kind of attacked by my traditional counterparts, because they're saying, what I'm saying is not accurate. In my bubble of integrative and functional medicine, yeah, we check hormones, we have evidence to support it, we have great clinical outcomes from patients. If you're somebody, I mean, just think of it as money. If you get a monthly paycheck, right? And you have so many bills to pay, and now you're not getting paid as much because you have a job on commission, you're probably going to go out and pick up another part-time job to pay your bills, right? That's what I would think about giving you a little bit of progesterone if that's what you're missing, right? You're still getting paid, you're still having hormones, but how about balancing it so it's equal? Because if you charge more on your credit card and you don't pay it off, what happens? You're going to have a balance. Even if you cut up that credit card, you're going to be paying on it for months. So if you have estrogen causing the lining of your uterus to grow up and your breasts, and you're not getting the balancing effect of progesterone killing those cells, there's a problem. And that's what's just like me banging my head against a wall for this.
So in the things that I read, and when they were saying that, sometimes doing that stuff is just not good. Do you think it's more so, getting estrogen or whatever, or doing something that's going to help during these times, like for instance, perimenopause? Is that coming from a place where they could potentially be giving, I'm trying to think of the right way to verbalize this. I am trying to figure out where their concerns are. What are the concerns with doing this? Is it because they're giving it to people that don't necessarily need it? It's something else? Or is it just there is legitimately a concern with doing this while going through perimenopause or whatever hormonal imbalance you may have?
So I can only speak to what is my practice pattern, what I do, and then what I've seen other traditional OBGYNs comment on. So for me, if you came into my office, I would start with blood testing, and I would tell you to go at a certain time of your cycle, right? And I would be checking hormones because you have irregular cycles. And 95% of the time, it's covered by patient's insurance. We order traditional blood work. So I'm not causing a cost to the patient. Then after the blood work comes back, if we see that your progesterone level is lower, I'm prescribing FDA approved bioidentical progesterone that you can get at CVS. Okay. That may or may not be, it's a generic medication, may or may not have a $10 copay, might have a $20 copay. I don't know. Generally is covered by your insurance. Sometimes not. Sometimes you would have to pay for it, but it's generic. Okay. So in that instance, you're not out any more costs. I mean, I guess you're coming to me. Sometimes the office visit is uncovered, right? Because of us taking a long time. I'm not doing anything that's not FDA approved. I mean, I'm prescribing an FDA approved bioidentical hormone. So I don't know why, because I've seen some of these other OBGYNs say that we're monitoring, we're profiting from the prescriptions, we're profiting from the testing, we're ordering this to get the money, but I don't really get any money from that approach at all. I mean, I don't get money from the prescription I prescribe. I don't get money from the tests. The tests go through your insurance. There's other testing that we do that is not covered by insurance. So that you may incur a cost. So for example, there's a saliva test. When do I use a saliva test? Well, in your blood, it's measuring the hormones that your ovaries make, right? And then it's putting it into the blood. And when we're measuring your blood, we're measuring venous blood. So the venous blood is the blood that's already been to your body and is going back out to be excreted, right? It's already taken everything to it. So if I want to see how much estrogen you have, because my concern is estrogen out of balance, my concern is estrogen because of uterine cancer and breast cancer, and also because of the symptoms. That's what causes a lot of the symptoms, estrogen out of balance from progesterone. Your body can make estrogen in your muscle and fat. And we don't see that in the blood because it doesn't happen in the blood. It happens in your muscle and fat. That'd be like saying my 19-year-old daughter is leaving my house on Friday night in sweats. And I think she's such a great kid. She's going to the library on Friday night, but she actually goes to her friend's house, changes into a tank top and miniskirt, pulls out her fake ID and goes clubbing. I don't see that happen because it happens outside of my house, right? All I see is her leaving the house. So blood is only one room of your body, right? So that peripheral conversion, which is well documented in our textbooks, happens in your muscle and fat. So my concern is that a lot of women, now think about it too, even today, like we have this obesity epidemic, right? And I believe it's directly related to our food, our hormones, insulin and everything, and our environment. Okay, I don't think people are really eating that differently, right? I mean, some people could be, I guess, because you think about the supersize me, but I think it's because of our environment, our detoxification, the chemicals in our environment that are acting as endocrine disruptors. So, I mean, I think there's a lot of issues there that my concern is preventing diabetes, preventing pathology. So that's why I'm taking a preventative approach. So the normal approach would just be wait till you have, gained so much weight, have a type 2 diabetic, and then treat you at that point.
So when it comes to if your hormones are imbalanced, what are the kind of symptoms that people would want to look for, whether it be someone that is young or someone that is older, or is it two totally different symptoms?
The symptoms overlap a lot. And the most common symptom that would alert someone to a problem is if you had heavy periods, if you had heavy or irregular periods. That may not be the most common symptom, but that's the one that at least we have a period. We know, wow, this is crazy heavy. I mean, if you're soaking a pad and a tampon in quicker than an hour, that's heavy, That's something that's
Mm.
significant. Even 2 hours, I think, is a heavy period. And some women, that's all they know, so they don't understand. Oh,
Right. I think what you know is what you know, and you don't think of anything else.
right, right. And I think because again, we're discouraged to talk about these things and complain about these things,
I
right?
don't even think I've ever had a doctor ask me, to be honest with you, how much do you go through? I don't think I've ever had a
I
doctor
yeah,
ask.
I ask all my patients, about their flow, how long it lasts, how heavy it is, how they feel, how many days. So that's an obvious one. There might be some really subtle things that you might not notice. One of them might be weight gain. One of them might be poor
Mm.
sleep. One of them might be, obvious ones like hot flashes and night sweats. But the big one that I see is an increase in anxiety, PMS. There's a lot of reasons for anxiety, both hormonally and non-hormonally. But I see that a lot of people
Do you
complaining.
think that maybe the reason why it's not taken as seriously as, other things that might be out there is because so many of those symptoms could be incidental and directed towards something else going on in their lives? Like for instance, the anxiety or mood swings could very well be, stuff is going on at home and stuff is going on at work. And, okay, so you have anxiety, but in the meantime, it could be your hormones.
Absolutely. I do think there's a lot of things that could contribute. But then again, if you think about it, if you have 5 girlfriends, they all have stress. We all, especially after last year, we all have stress. So why do
Mm.
some of them suffer from anxiety? Yes, it's
Because they're tougher or they're more disciplined or, there's all these different reasons that we come up with.
yeah. I suppose personality does fit into it, but absolutely, I think it has to do with your hormones because progesterone is a natural anti anxiety in your body. And if you don't have the
Mm.
same amount, you're going to have you're going to have different symptoms. So I think because, we are taught that these are the symptoms of perimenopause, right? You're not taught that these are the symptoms that you can do anything about it. We're basically taught that, you can have hormone replacement when you're in menopause. You're not taught to do anything for perimenopause, but I cannot tell you, I've been doing this for 15 years and
Mm.
probably over 15 years. I'm personally taking progesterone. It makes a world of difference. And if you're, and I, knock on wood, I have not had any adverse effects from people that it's relatively safe. There are certain people that have some strange side effects, but for the most part, it's well tolerated. Like I said, it is FDA approved. It's generic. It is, mostly covered by insurance. So I don't get what the issue is with prescribing that.
So if a person decides, all right, they're having all these things and they kind of suspect this is what it is, it's a hormone fluctuation. But they decide they're going to tough it out, which I always find really fascinating when people are just like, oh, I broke my toe, I'm going to tough it out
Right.
instead of getting the medical help. Are there long-term ramifications of this? It's kind of like you were saying with diabetes. It's kind of like, oh, I have diabetes, but I'm going to solve it myself, or take care of it myself. And really, in all honesty, you need medical intervention. Is there a consequence to just letting it ride and just toughing it through?
That's actually a great question. And I think, when we talk about personalized medicine, this is a place where we absolutely have to personalize every single person. So
Mm.
the answer is different for everybody, right? So for you might be different for me. So let's take 3 patients, for example. One patient would be somebody like me who struggled with infertility, had very, very low estrogen levels, since my early 40s, and I've been taking hormone replacement. Now, low estrogen is also linked to osteoporosis.
Mm.
Osteoporosis is actually the death rate 2 years after a hip fracture is higher than 10 years after breast cancer diagnosis. Also,
Wow.
low estrogen and early menopause has been linked to an increase in cognitive decline and also heart disease. Both of those things have been reversed when you take estrogen. So, what is your risk factor? Your highest risk factor is you're going to die of a heart attack. That's the number one killer in women. So, we know that estrogen has had a positive effect on that. So, for the person who normally is low, the benefits of hormone therapy may outweigh the risks. And then you might have someone in the middle category, someone who has a lot of estrogen, makes a lot of estrogen, but it isn't balancing with progesterone. That's a common scenario because progesterone comes after ovulation. We know that over 35, your advanced maternal age, if you get pregnant, because the quality of the follicles aren't as good. Well, if the qualities aren't as good for the baby, they're not going to be as good to produce hormones. So we normally see the old eggs not producing as much estrogen. So then you have estrogen here, progesterone here. That's like charging the credit card and not paying it off. That can be linked to breast and uterine cancer. So the consequence of doing nothing in that patient is serious, right? And then you have the third patient who, I always remember I had this patient when I was doing just regular GYN who was a dairy farmer. And she got up super early, she worked, she constantly was working on the farm. So she was moving, she was exercising, she was sleeping. She went through menopause and she didn't need any hormones. She was making all her own food, never ate out, and ate organic and, exercising and prioritizing sleep because she had to get up early. So she had a very simple life and she never needed hormone therapy. So I think everybody's different. I mean, there are certain things. We just finished our boot camp last week. We have a boot camp that we run people through online that what are the things that you can do to get to fix your hormones without any hormone intervention, so we talk about what to eat, when to eat, detox and all those things. So there are things that people can do without taking hormones also. So we don't know who's going to need hormones and who isn't.
It is interesting that you were talking about the dietary changes and everything, because I do feel as though nowadays more women obviously are in the workforce. They're kind of doing it all. They're taking care of their family, they're taking care of their work. And then we wind up going for the more easy access foods. All right, maybe we do in this family sometimes, where it's something that it's like, all right, let's just throw it on real quick. Like, oh, we can microwave this real quick. We can throw it in the oven. It's already prepared. We just have to heat it up. So I do think that it's potentially could have more relevance now. But what are the things that we're grabbing that could be potentially affecting our hormones? In other words, when it comes to, I would assume processed food, but what is there a specific food or group?
Food is a big thing. And if I had just one simple dietary hack for people is don't eat anything you can't pronounce. So if you're looking at ingredients, you don't know what they are, I wouldn't eat it or buy it. Now, do I ever eat something with a barcode? Yes. I eat crackers. I eat things, but for the most part, I make my lunch every day and I generally make my dinner, but there's some snacks that are somewhat processed, but I like to look at the label. And if it says, potato, salt, oil, that's it in your potato chip, that it's better than all the other processed things. So processed food is one of the things. The other thing, I guess I have a bad sweet tooth also. And I didn't realize how much added sugar is in a lot of things until I did an elimination diet where you could only have like a total of 5 grams of sugar in the whole day. And there's so many.
Even I know that's a big challenge and I'm not a big sweets person. Wow.
Yeah. There's so much added sugar in a lot of those processed food. That's part of the problem, right? The second ingredient is high fructose corn syrup, right? And so that's part of the problem too. And things like yesterday, I went out to eat and I ordered coleslaw. I know it had sugar in it because I could taste it. I was like, who puts sugar in coleslaw,
So how does sugar directly affect hormones? Because this is, of course, it could be any time of a person's life, a woman's life, that they could be eating a lot of sugar and it could affect their hormones. But I often think of some of the young women I know that are in their teens or in their 20s, that, you kind of younger, your body processes a lot more quicker and everything like that. So you can get away with a little bit more than when we get older. So, what exactly is sugar doing to our hormones?
So let's just say that sugar is a car, right? And we're used to getting, let's say, 10 grams of sugar in our food a day. Like when you and I grew up, let's just say that was the normal. Okay. And now people are getting 50 or 60 grams. And I'm just throwing out these numbers. I didn't look them up, but I believe them to probably be partly accurate. I'm sure it's about that much. Right. And so let's just say now, so if each, gram of sugar is a car, insulin has to take the car and park it. Right. So you got the cars in your blood, right? You got to park them eventually, right? So insulin is the valet parker that's taking the car and going into the cell and parking it. Well, there's only so many parking spots, right? So after the cell is full of glucose, it's going to start saying, we don't have any more room. This lot is full, right? So the lot's full. Then what happens? Well, then there's more cars. Then they got to hire more valet parkers. Okay. Because there's so many more cars, you got to drive further to try to find a lot to park the car in. Right. So then they're gone longer, then you need to hire more. So insulin starts to go up and up and up and up because the cell says, you cannot come in here, and it's resisting. And insulin's job is to get those cars parked out of the blood. It wants to get your blood sugar down. So insulin goes up, 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 and starts you start getting insulin resistance, right? It doesn't respond to because there's so much sugar around. That starts affecting your ovulation. It affects the way your body gets rid of estrogen. It affects your cortisol. Cortisol affects your estrogen and your ovulation. So cortisol's job is to get blood sugar up because cortisol wants you to run from the bear. In order to run from the bear, you need sugar to get to your muscles to fuel your muscles so they can contract, right? So the cell can work to run from the bear. So cortisol is trying to get it up, insulin's trying to get it down. And so they're fighting each other, and that's going to add to it. That's stress. It's going to add to it, increase, increase, increase. There's only so much parking spots that this sugar can go. And sometimes they can move them around and they can recycle sugar and make it into something else, but your body wasn't made to handle all that. Mm-hmm. So that starts disrupting all the rest of your hormones. And then if you have cortisol and you have stress and you have all that on top of it and aging and, so estrogen, you're not getting rid of estrogen as fast. The other thing that it does is the whole Alzheimer's thing is beta amyloid plaques. Well, the enzyme that breaks down the beta amyloid is also the one that's involved in this sugar insulin issue. So if it's so inundated with this, it's not breaking down the beta amyloid plaques, and it's been shown to be linked to Alzheimer's. We call Alzheimer's diabetes type 3 because there's a huge sugar link to that.
I want to ask about cortisol and its link to hormones, because I often hear a lot of when you're going through a cycle or let's say perimenopause or any other kind of things, their cortisol, look out for that cortisol belly or whatever. I don't know. It was a lot of weird things I was reading. Do they have a direct correlation, or is just one is triggering the other because of the stress levels coming up?
So you mean the belly fat?
Well, I mean, just hormones and cortisone levels. I mean, do they go hand in hand when there is like an imbalance? Or is that just it's just incidental?
Yeah, all of your hormones are very interconnected. So let's just start with cortisol. If cortisol is high because you're stressed, maybe it's work, maybe it's anxiety of pandemic, maybe it's a working mom, whatever it is, some extrinsic stress, cortisol goes up. And it's supposed to go up, and then you're supposed to have rest and recovery, right? Well, that's not what happens, right? It's not life or death. It's just elevated and it stays high. Right. Then you end up having a problem. If you have high cortisol, your thyroid doesn't work correctly. So it affects the way your thyroid works. Your thyroid gland produces T4. Your body's supposed to convert it to T3. That's like your paycheck. You can't go into CVS with your paycheck. You got to cash it. Cashing the paycheck is like converting T4 to T3. Cortisol is going to inhibit that, right? Because if your body's running from a bear, you don't want to rev up the metabolism. You want to conserve it, right? So the thyroid gets affected. If you're running from a bear, do you need to ovulate and reproduce? No. So high cortisol can inhibit the release of the hormones from the pituitary gland that stimulate ovulation. You know how women skip a period a lot of times when they're stressed or something happens?
Oh, yeah.
Heavy periods. That's the effect of cortisol. So, but the problem is we're not in life or death stress. We're in chronic, unrelenting stress with no reprieve. So we don't have a break from this stimulation. So it's very insidious that you might not even feel stressed. Like you said, I'm a mom, I'm working, I'm taking care of my kids. That's the life you've known. Some people have some great adaptations to stress. And there's been a lot of focus on this lately, which is really exciting because of the pandemic, there's been the focus on mental health and focus on stress relief. And next weekend, I'm actually giving a TEDx talk on this exact topic on stress.
Oh, how exciting.
Yes. Yeah. So my topic is stress and my tools to manage it, and the tools that that have the science behind and that I felt were helpful. So it's a topic that I dig into a lot and I'm asked to speak about. But I think the problem is we don't give enough respect to stress, right? I can't imagine a time of my life when I wasn't stressed. I graduated from high school at 17. I started college a week later, finished college in 2 years, went to medical school at 23, was a doctor, went into one of the hardest residencies ever, and then went into being, a private practice mom, infertility, all this stuff. Then 3 kids in 3 years, 4 years. So, it was a lot. And so I don't, but stress is normal to me, but that's not good, right? That I don't remember a time of not being stressed.
Yeah, no, that can't be good. I sometimes sit there and I rationalize it in my head thinking, well, I think some people have a certain tolerance level and that the cortisol is not like, in other words, they handle the stress and they just go through it and their body just has adapted to it. And it's only like the real true spikes that their cortisol probably go up. But I have a strange feeling that's not true. And I have a feeling that's probably why there's so many issues.
I mean, I do. I mean, the leading researcher on stress, Hans Selye, said it's not the stress that kills us; it's our reaction to it. So there's some truth to what you just said. Is that, and I think is that biochemistry, individuality, is that just your personality, how you were raised. I don't know. Like some people don't get stressed.
Nurture over nature, right?
You don't know what that is from. I feel like. And maybe I'll send you the link after the talk comes. I feel like you'll hear.
Please do. No, definitely. Well, we'll have to post it along with the podcast because in all honesty, I think it's such valuable information, especially as everything has been. I do like seeing so much out there and especially on TikTok and whatnot, where we're really talking about these things. Is that how you got into making these posts on TikTok?
Well, it's funny, I have 3 college age kids. Well, actually one of them graduated from college. So I was like, they were talking about TikTok, and my younger daughter, who's very quick to make fun of me all the time, she actually told me that I should be on TikTok. And I'm like, I looked at it, I'm like, it's like dancing. I'm the worst dancer. I can't dance. I can't do any of that. And she's like, no, Mom, I think there's a lot of, doctors here. So I got on TikTok and kind of just for a week, just like watched what everyone was doing and studied it, And then I put my first couple posts actually were on birth control pills, what we just talked about, using them instead of treating the cause. And I very quickly, like I think I have 260,000 followers and it's been like 5 months or something like that. And just because I think I'm hitting a chord and it's been.
I do feel like education TikTok has really kind of shot up lately. The more expertise that you have on a particular subject and you're able to share it, really people are very attracted to it.
Well, my primary goal is to educate people. I mean, because we're bound by licensure. I can't see everybody. I mean, you have to only whatever states you're licensed, you can only see patients in that state. I don't really need a lot of more patients, so I'm mainly I'm shocked at how many people reach out to me that either they've been told their symptoms are normal, there's no reason to check hormones. So I'm mainly trying to advocate for patients, like to help them how to advocate themselves and maybe even embarrass my kids a little bit on TikTok too, or whatever. So those are my 3 reasons. So, I mean, going in with that agenda, I don't have an agenda to sell anything or do anything. And, if that happens, that's fine, but that's certainly not my agenda because I just have a passion for just like, especially when I hear people say they've been told they're normal and they're really suffering or they really feel like, and again, there's a lot of great doctors out there. So there's a lot of people who are learning and open and trying to help their patients, but there's also people who have no interest in this and just we're taught that there's no reason to check hormones. So that's just what they're passing on. They're just taught that. They're not trying to be, malicious or anything, but that's how we're taught.
So let's with Beauty Uncovered, one of my favorite things about us is that we are always looking to empower our audience. So obviously, they can listen to all of this, but it doesn't necessarily going to equate to any particular action. Obviously, everybody's health is individual, like you were mentioning. So for any of our listeners, what are some of the things that they can do when they're researching doctors? What should they be looking for? What kind of conversations should they be having? And what are like the telltale of, I don't think this is an area of, I guess, OBGYN or whatever, practice that they have that maybe this is not something that they do. In other words, I think that's really a hard thing is finding a doctor that's the right fit for your needs.
Yeah,
So
that
what
is
should they be
hard.
looking for?
That is hard. And now with today's day and age, with websites and social
Mhm.
media, you can do even more digging before you make that first appointment. You can look at their website, you can look at their
Yeah,
social.
because before it always felt like a crapshoot.
Yeah, you would get a list of who was covered on your insurance, and you would look based on geography. This one's
Yeah, or hope that you had a friend that could refer you to someone and then like go through your insurance going, oh, yeah,
yeah.
they're covered on my insurance.
Yeah, I've been, I mean, there are some great OBGYNs that are out there. Like, so if I made a post, some people have said, oh, my OBGYN did this. And I'm glad to hear, like, I'm a doctor. I don't want to slam other doctors. That's not
Mm-mm.
my point. My point is just saying, if you can kind of get an opinion, you can kind of get like, if you ask a question in the whole facial expression, right? That reaction
Yeah.
to like, whatever. People will come in with stacks and say, I did this search on WebMD or whatever, and it never offended me, right? I mean, I just like, oh, okay. And if someone asked me about something that I didn't know about, I'd be like, I can't really speak to that. I don't know, but I'm willing to look into it. That's just been my personality. I mean, I guess I had an overbearing father that told me I always didn't know anything. So maybe
I think it's an understanding of having empathy of how people are just trying to do their best. I mean, I'm completely different field. I'm in the hairdressing field, but the amount of times I've had people saying, well, I use box color, or, I sometimes used to cut my own hair. There are some hairstyles that would get very offended by that. Where me, I'm just like, that's life, that's
right.
fine. Let's see what we can do from here.
Or they come in with a picture and you're like, there's no way your hair will do that, right?
Yeah.
So they
Yeah.
want that, but they can't, it's not good for them or whatever. So that might be the thing. It's like,
But it's not an offensive thing where you're going, oh, are you kidding me? No, it's, okay, let's talk about this.
I think you're right. I think part of it is your personality. I think the second thing is time. When I used to do normal OBGYN, I had 45 patients a day scheduled. So what that meant was if I had an OB patient, you had about 5 minutes with that patient.
Yeah.
For my patient, you had maybe 7 to 10 minutes. And in that time, you have to do their breast exam, their pap smear, listen to their heart and lungs, ask them everything else you have to ask them, refill a prescription. So if someone asks about, look at how much long we've just been talking about questions you had. I mean, that's our appointments in my office are 45 minutes. Some of them are even longer than an hour. The first appointment's generally an hour, sometimes longer. So because it takes that long to explain a lot of things, to ask all the questions. So I think time is the other thing, because when the insurance model changed, and then you started to have to get paid by volume, then you got to see more patients, you have less time with people. And that's part of the reason why the insurance model doesn't work for integrative or functional medicine a lot. It's not that you do the math. If you see 45 patients versus 8 patients a day, you're going to pay a lot. You're going to get paid a lot less, and you still have the same staff, rent, utilities, all that other stuff, right?
It's very interesting because when my eldest, who's 23 now, when he was an infant, we had moved back to New York, and I was trying to find a pediatrician, and my friend recommended his pediatrician, right? So he was an older man. He was very close to retirement. So I knew I was only going to have a few years with him, but he deliberately would block half-hour appointments for each one of his patients. Old school, sat there, talked. Old school, sat there, had a nice little conversation with how things going on at home. How's he doing with this? And it was delightful. I'm not trying, and it's like you said, I'm not trying to bash the ones that are doing, 5-10 minute appointments. The truth is that unfortunately they have their own constraints as well, and I understand that.
They're locked in hell. I mean,
but it would be lovely to come back to that kind of simplicity. It would make it easier for doctors and nurses to be able to really do patient care as opposed to, I don't know, what is it, a checklist?
I don't know if things are that much more expensive or it's the insurance people coming into the middle, right? Because I started in private practice just as that insurance, third party thing was taking off, right? It was just starting. So I worked in a private practice. My mentor who hired me, he was that guy who would sit forever with you. And I remember when I was a medical student, one of his patients got in a car accident. It had nothing to do with OB, but he stopped in the ER to talk to them and give them reassurance. When he found out I was in labor, he left an office full of patients to sit with my parents for 4 hours while I pushed. I mean, that's the kind of guy he was. That was the model that I was shown as a student and as a young physician, was his model. And that's that generation that doesn't exist. So then when insurance came in, they had to regulate, you have to do all these things and you have to see this many people, because yeah, you're going to charge us $150 for the well visit. We're going to pay you 70, whatever. And then you have no recourse. You just got to take the 70, because if you say, well, I'll just work directly with the patient, I'll be out of network, patients won't come to see you, right? Because if they can't use their insurance, and then the patient's paying the insurance company is not paying us the whole money. Who do you think is getting the money? I mean, just look at like a lot of the big buildings downtown, and any like has their, Aetna, Anthem, Blue Cross Blue Shield, these big towers or whatever. It's not coming to us. And so these doctors are forced to now see patients less and less and less to meet these guidelines, to stay up, and it just doesn't work. And that's why when I started my practice, we were on insurance for many years. We just couldn't make it work with seeing 8 patients a day, and and it just was. And then we went to half an hour visits, and I just didn't feel good about that, And so it was a risk, and so, like I said, it's not, most of the time people are not in this field because it's lucrative, right? It's not like, it's because you have a passion, you have a personal story, and this is what you want, to help other people through. Generally, either you've had a health issue or family members had a health issue, so you've studied integrative or functional medicine because of that, because you see where, the traditional model fails. I mean, the traditional model has been great, obviously, to deal with tumors and heart attacks and trauma, right?
Right.
There's no other way of car accidents, of treating that kind of stuff. And we need it the way we have it. So, but it's this chronic disease, it's this wellness and prevention area where I think we're dropping the ball.
That is a very true statement. Like I said, when I was younger, I even worked for a radiologist when I was like 19, 20 years old. And the difference of seeing how things are done now as opposed to then, it's really stark. It's different. It's very different. So with that being said, I'm excited about this TED Talk. Please send us the link, and we'll be sure to put that in our description, because that sounds really exciting to listen to. And I'm really grateful for you to coming on today. Thank you.
Thank you. Thank you for connecting.